Welcome to today's webinar on carpal tunnel, the who, what, where, when, and why. We know this is a topic near and dear to many of your day-to-day work. My name is Barb Robinette. I am Chief Marketing Officer at Empyrean. We're excited to have all 400 some odd of you today. I think we'll probably get a few more that will join us in the coming moments. When it comes to questions and answers, you have the opportunity to submit text questions to Dr. Vender, who's our esteemed presenter today, by typing your questions in the Q&A panel. And you can send them in at any time. We will probably hold off on them until the end of the presentation so that we can make sure we get through all the content. But there's always the possibility we might throw one out there if we have a moment. You'll see the little Q&A icon at the bottom of your webinar window, and you can enter in that question and submit it on. Let's see. It's a little slow today. Not sure why the screen's not moving.
Let me see if mine is.
It is. Okay.
That was me.
Okay, I don't know what happened there. So today's presentation on carpal tunnel will be presented by Dr. Michael Vender. Dr. Vender is a board-certified orthopedic surgeon. I'm not going to read all the details that are on this particular slide, but I will highlight a few. He earned his MD from the University of Illinois College of Medicine, completed residency at Northwestern University, fellowship training in hand surgery. He's a recognized leader in the field of hand and upper extremity surgery, decades of experience, listed among Chicago's top surgeons, active member of the American Society for Surgery of the Hand, as well as American Academy of Orthopedic Surgeons and Chicago Society for Surgery of the Hand. Dr. Vender's experience is quite extensive, as you will come to learn as we hear from him on the topic of carpal tunnel. And we will be recording today's session for those of you who want to send it along to a colleague to listen to. We will also send out the slides, and we are going to go ahead and hand things over to Dr. Vender, who will tell us what we need to know about carpal tunnel.
Okay, Barb, Dana, and everybody else, thank you for having me. I'd like to mention Barb and Dana. I've done a lot of webinars, a lot of in-person presentations, large crowds. This is about as professional and well organized as anything I have ever done. So thank you for that. Knowing the magnitude, I don't know what I was thinking about before, because I rarely come to work without a tie. So here I am in front of all you without a tie. And even worse than that, I chose a boring suit. So my apologies. Maybe next time around I can do better. So,
You're great.
But thank you. All right. I do have decades of experience, as you can see. And as you'll see in the presentation, we're going to talk some medicine, and we're going to talk some medical legal. And there are a lot of good doctors out there who can take care of patients and do a good job. Medical legal and handling workers' compensation is completely different than handling a private patient. Indications for surgery, expectations for recovery, extra questions that have to be answered. When can they go back to work? Causation, the usual things. So this is titled Causation and Evaluation of Upper Extremity Disorders. There's lots of things that could be titled. I'm supposed to talk about carpal tunnel, and of course I will, but that's actually going to be a small part. So we'll talk about bigger pictures than just what is carpal tunnel syndrome. I am in Chicago. I'm part of a hand surgery group. All we do is hand surgery. At this point, we're still the largest in Illinois and Chicago and most of the Midwest. And this practice was founded in the 70s based on workers' compensation. So an IME, let's back up a little, because we're dealing with, I believe, adjusters and maybe some case managers. You know, an IME is very central to the process of workers' compensation, and it usually comes down to a few issues. The most basic is, what's wrong with this person? What's the diagnosis? You know, what treatment is needed? But then after we have a diagnosis and treatment, is this really a work-related issue that we're responsible about, or is it somebody else's responsibility? So we have causation. And then again, regardless of causation, what is this a person's work capabilities? So those are the main issues. So let's talk about the process. How do we start? Of course, patient comes in, we do a history. We do a physical examination. We do tests. The routine tests, of course, are x-rays that can be performed in the office. Sometimes as part of an IME, I may suggest an MRI, a CT scan, an EMG. So you won't get the full opinions until further tests maybe are obtained. Then you come up with a diagnosis, and then you do your comments or recommendations. That goes back to the issues we were just talking about of, causation, treatment, work capabilities. So that's what that means. So the most basic thing is, causation. When I first started in practice, my idea of causation was if the patient said they used their hands at work, then everything wrong with their hands was related to work. Very simple. I mean, of course, it made sense, right? You work, you use your hands. If you have a problem, it must be work. And a lot of doctors still believe that, because it's at least in Illinois, it's beneficial for someone to be workers' compensation related as opposed to private insurance. So that's a money issue, a bias issue. So the level of sophistication in giving an opinion is either non-existent, very low level of sophistication, or they don't care and they're just going to say everything is work related. Now, the NIOSH, National Institute of Occupational Safety and Health. So most people have heard of OSHA, which comes into a workplace, punishes the work environment for work, injuries, etc. They're enforcement people, OSHA. NIOSH is the other branch of this organization that's involved in research, trying to determine what's happening in the workplace. So they're trying to figure things out. OSHA is trying to do enforcement. Now, I'm not a big fan of big government, but this is one of the best things that I think government ever did, was come up with these criteria for work-relatedness. They actually came up with this. They come up with a lot of stuff that I disagree with. This one I think is really pretty commonsensical and it works. But nobody uses it because nobody's ever heard of it. Trying to advance. Hold on a second, everybody. Oh, there it is. Okay, good. So there's 6 things that NIOSH says you should do for determining causal relationship. The last one just being evaluation and conclusion. We're going to talk in this talk about the first 3 only. So number 1, consideration of evidence of disease. What that means is you have to have a diagnosis. You can't determine if something is related to work if you don't know what the thing is that you're trying to relate to work or not relate to work. So you just can't say a person has arm pain. That's not a diagnosis. You have to have something that's a real diagnosis. Carpal tunnel syndrome, tennis elbow, cubital tunnel syndrome, trigger finger, arthritis in the hand. So until you have a reliable again, I also use the term reliable, not just a diagnosis, but a reliable diagnosis. You just can't make something up. Until you have a disease or a problem, how am I going to determine whether it's related or not? Next thing, consideration of epidemiologic data. We'll define epidemiology later. It's a fancy word. What that means is there anything in the scientific literature, medicine, hand surgery, orthopedics, epidemiology, is there some kind of studies out there that show that work activities can cause disease processes? Are we just making it up? Or have people actually studied it and tried to come up with a reasonable explanation via studies? Lastly, consideration of evidence of exposure. This could be one of maybe the most important point I'm going to make as we get to it later, because I'm going to go through these. Evidence of exposure. meaning what are they doing at work? That's evidence of exposure. Okay, so let's get to evidence of disease. How do we know there's a disease process? How do we know there's carpal tunnel syndrome? How do we know whatever is present? Well, like any evaluation, whether it's a work-related problem or a private patient, you talk to them. Tell me what's wrong with you. Okay, that's called the history. We do physical examination. Now, okay, I get an idea of what's wrong with you by talking to you. Let me do a physical examination to see if they correlate. And lastly, I get tests, either to verify things or to try to get new information on making the diagnosis. So once I go through that process, I come up with, hopefully, a diagnosis. Not always. I usually have an idea. If I'm only really not very sure, I don't want to put down a diagnosis, because once I put it down, that patient is labeled forever. Okay? So I may be thinking about something, but I don't like to put it in the chart until I'm more confident. However, the way electronic medical records are going nowadays in billing, sometimes you are forced to put down a diagnosis, which is unfortunately counterproductive. All right, it's a little slow on the advancing. So how do we get evidence of disease? For some things, we can do tests. You can do x-rays, you can do MRIs. When it comes to carpal tunnel syndrome, which we're talking about today, it's based on history, physical examination, nerve conduction studies. The latter is very important because this is one of the major disease groups where we do actually have objective findings, a test, where we can actually do a test. Because doing physical examination is not very reliable. So let me back up a little bit and say history, physical exam, EMG, nerve conduction studies. To me, you could pretty much drop out the physical examination. But in your mind, leave all three of these things in your mind as to what it takes to diagnose. Even though I'm saying you can do this over the phone. So if someone wants a causal relationship on a carpal tunnel case, I don't have to see the patient. This is one of the few times I could just do a record review. Because to me, the most important things does the story sound like carpal tunnel syndrome? Yes, it does. Do they have a positive EMG? Yes, they do. Okay, that's carpal tunnel syndrome. What happens if we go backwards and they say, we ordered a nerve test on this person and it shows carpal tunnel? And then I go back to the patient and say, tell me your symptoms. But they don't have numbness and tingling, which is the basic symptom. They don't have carpal tunnel syndrome, even though the EMG is positive. Because you can have abnormal tests, whether it's called that false positive. You can have an abnormal test, whether it's a CT scan, whether it's an MRI, just because how many times have you seen an MRI come back negative? They find 15 different things wrong on them. Do these people really have 15 things wrong? Of course not. These are incidental findings. They're degenerative processes. They're not necessarily symptomatic. Therefore, they don't necessarily represent a disease process. So if someone has a positive EMG, I want to know what their symptoms are, and vice versa. Just because you sound like you have carpal tunnel syndrome based on your history, I want to verify it. People know what the symptoms are. They can make up the symptoms. Everybody, to some degree or another, has numbness and tingling in their lives. So you just can't go by the history. You'll want the two things together. I still, of course, physically examine them, because if they do have carpal tunnel syndrome, you can see whether they've had change in sensation, whether they've had muscle loss. More important, when I'm examining somebody who could have carpal tunnel syndrome, I want to examine them to make sure they don't have something else. Because if they have arthritis in their thumb, I fix their carpal tunnel, they come back and continue to complain of pain, well, you can be confused. Did I not fix the carpal tunnel? Is there something wrong with the surgery? No, they're still going to have pain from the arthritis. Even more subtle, they could have a trigger finger. Now they come back and they say, well, you fixed my carpal tunnel. I think my numbness is gone, but my hand still hurts. You say, oh my gosh, maybe we'll have to go back and do the carpal tunnel again. Well, it's a trigger finger. So both preoperatively and postoperatively. Preoperatively, you want to check, make sure they don't have other things. Post-op, if they have complaints, you got to make sure there isn't another condition that was either present or has developed since the surgery.
Dr. Vender, we do have a question that's probably pertinent to go ahead and address right at this moment.
Great.
What if the patient has a physical exam with symptoms of carpal tunnel, but a negative EMG? Is carpal tunnel surgery still indicated?
Perfect. Let's go to this slide. So you say it's based, you see something on physical examination. What is it that you see on physical examination? Because, and this is cultural. And I know that we have all these people all over the country, and a lot of things that happen in different areas are based on prominent surgeons who get their opinions out there. So what someone in Arizona may say is different than what I say. And but one of the things that we're all taught in medical school and even in training is physical examination findings of carpal tunnel syndrome. So it's a good question. You look at the reports, all the things that are coming across your desk. Everybody's talking about Phelan's test. They're talking about Tunnel's sign. They're talking about forearm compression tests. They're talking about 15 different tests to look for carpal tunnel syndrome. Well, first of all, there's 15 different tests. That's telling you none of them are that reliable. Because why do we need 15 different tests if something's reliable? The Phelan's and Tunnel's are good tests. Why do we need 13 others? The reason we need all these tests is none of them are reliable. Everybody's trying to come up with a better answer. So they have someone with positive Phelan's, positive Tunnel's may not have carpal tunnel syndrome. Tunnel's is where you tap over the nerve. Well, I could tap over somebody's nerve and get a positive response on everybody, depending on how hard I hit you over that nerve. So all these tests are subjective. They're subjective in how the doctor performs them. It's subjective on how the patient responds to the test, because they have to give you some feedback. And it's subjective again on how the doctor interprets that response. So this again is something, because this study was published by somebody who's very pro work causing problems. So you would think that they would not publish a study like this, where it says all the things that are used by NIOSH in screening are actually unreliable. So that comes down to, I do not believe there are positive things on a physical examination that are going to change my mind, because these are all reliable. And I do get these questions, especially in the deposition. Well, what about the positive Tunnel sign, positive Phelan's? Doesn't that prove that they have carpal tunnel syndrome? Absolutely not. The other thing that's a little confusing is I do believe that there's a concept that you could have a negative EMG with carpal tunnel. That may be based on the quality of the person doing the test. Maybe they're just not picking it up, or maybe that condition actually exists. But all I can tell you, 40 years in practice, I probably haven't operated on a negative EMG since maybe early when I was in practice. So if someone's got carpal tunnel syndrome and they need surgery, they're going to have a positive test. Or put it another way, the downside to not doing the surgery in someone who's got a negative test, because again, how bad can it be? The downside is not as bad as the downside of doing unnecessary surgery on the wrong patient. There, especially in medical legal situations, car accidents, workers' compensation, it opens a whole can of worms. So it's all risk benefit. Do I really want to operate on that type of patient? Or do I want to take my chance at possibly delaying a surgery on somebody who may need it in the future? How bad can the condition really be? I hope that answers the question. If not, we can revisit it later. Good question. All right, I'm sorry about the advancing here. It's moving a little. Okay. All right, so that was carpal tunnel syndrome. Not all conditions have a test you can order. Lateral epicondylitis, tennis elbow, that is. Let's go to ulnar neuropathy, because that's a nerve test too. That's a nerve condition, nerve test. Clearly, there are more negative cases on EMGs that I will still operate on Not a lot, but that I'm not as rigid on as saying you have a negative test, therefore, there's really nothing significant wrong with you. So ulnar neuropathy, I'm a little bit looser on. So let's go to the epicondylosis, the tennis elbow, the golfer's elbow. That is mostly really based on physical examination. Do they have the provocative test? Do they have the reliably local tender areas where they should be tender? Not areas where they shouldn't be tender, but are they tender where they should be tender? So that's physical examination in history. Even me, before I would operate on somebody, I do get an MRI. But again, I think MRIs are extremely overread as to what they find. Even by my own interpretation, when I look at my own MRIs, it's hard to find normal looking tendons. There's just a natural degenerative process. So if you're only going to make the diagnosis based on the test, you're going to have overdiagnosis. They really do have to have a reliable physical examination. All right, you're up.
Great. Everyone should be seeing the poll question come up.
I'll give you my text. If you don't know the answer, you can text me and I'll give you the answer. I'm only kidding.
All right, we can continue moving on while everyone's taking the poll question.
Okay. All right. We just spent a lot of time on diagnosis. So let's go through epidemiology. That's the number 2 thing on the list from NIOSH. Epidemiology is the distribution and determinants of disease among humans. It's the study. So if you want to know if something's causing carpal tunnel syndrome, you go to a plant and they say, we think we have a problem with carpal tunnel. We have 1,000 people here and we have 20 cases of carpal tunnel. Do we have a problem? 1,000 people. So the idea of epidemiology is to compare groups. So you have the 1,000 people in this factory, then you have to go get 1,000 people that are similar to that factory. The same number of males and females, the same age distributions, hopefully the same number of people with diabetes and other medical conditions. Can I close this? It's in. Yeah. Okay. So you have 2 groups of people, 1,000 each, one performing this work. The other people and the other group are the same type of people, but they're not performing that same type of work. So lo and behold, you have 1,000 non-workers, and they have 20 cases of carpal tunnel. That shows there's no increased risk of the factory causing carpal tunnel syndrome versus the people outside the factory. That's how you have to study. Is doing this activity harmful? How do you compare it? Compare it to a similar group of people who aren't doing the same activity. Let me see what the next slide is. Okay. Oop. Oh boy, I skipped ahead a couple. Oh, hold on. All right. So it's interesting. There was a study done many, many, many years ago, because a lot of the stuff that they're losing interest in it. A lot of researchers lost interest in this topic. There's a study years ago from, I think, one of the telephone companies. They had 3 data centers in 3 different cities in the West. Denver, I'm making this up, Denver, Utah, and say Los Angeles, 3 different locations. So you have, again, let's use the number 1,000 people in each location, similar distribution of the types of people, but one group, the people in Denver, had astronomically more cases of carpal tunnel syndrome, work-related carpal tunnel syndrome. So the question, that begs the question, you have 2 other locations that have similar incidents, similar rates of disease. But why is there so much in Denver? There was a doctor who was treating these people. Overdiagnosis, overtreatment. So that's where I was talking earlier about culture. What kind of city are you in? What kind of doctors run, the hand surgery aspect? What kind of unions are there? What plaintiffs and petitioners, lawyers are control that, and what doctors they send it to? these are very unusual circumstances on how medicine can run amok. Okay, now let's go back to what does the epidemiology say? If you remember in the old days, I don't know how old this group of people are, but in the old days, everybody thought that typing caused carpal tunnel syndrome. It was in the newspaper, it was in our Chicago Sun-Times. People were suing IBM, who made the keyboards that people used. None of the suits were ever won. Studies came out and showed that there is no causation between typing and carpal tunnel syndrome. So hopefully that's gone away, though not totally in Illinois. But what do we worry about? I'm asking a deposition, what do I really believe? I really believe it takes a lot to make something work-related. My threshold is hard, it's pretty high. But the mantra I usually use is, if I'm looking for carpal tunnel syndrome causation, I say forceful, exertional activities on a regular and persistent basis with duration. So that almost eliminates the concept of repetitiveness. It's got to be forceful. So just wiggling your fingers does not cause carpal tunnel syndrome, even though it's repetitive. It's got to be forceful. Now, does that mean any force? No, we all use our hands forcefully. We go to the gym and use our hands forcefully. We send patients to occupational therapy. They use their hands forcefully in their rehabilitation. So now you're looking for force with duration. So there's a difference. If I'm looking at somebody who has to lift a 50-pound box 100 times a day, that's pretty forceful. 100 times a day, okay. But they lift that box to move it 3 feet. So not a lot of duration of that force, right? 50 pounds, 100 times, they're only doing it for 3 seconds or 3 feet or 5 seconds versus someone who's lifting 50-pound boxes 100 times a day. They have to carry it 20 yards. They have to carry it. Now you're getting into duration. So that's my feeling. If you show me somebody who's doing a physically demanding job for a significant portion of the time with duration, I'll probably say a positive causal relationship. So that's sort of the way I look at it. But let's get into this concept. Just because somebody does forceful and exertional, or we know that the literature says if you're doing these forceful and exertional activities, and now begs the question, what is this particular claimant doing? We know that if they're doing a certain job that I just described, this is going to be a positive causal relationship. So now we need to get into what is necessary, not just the general concept, but the necessary to determine causal relationship. We get into, this is the number 3 in the slide, evidence of exposure. So, all right, we know that this person has a forceful job and this and that, but we really need to know specifically how forceful, how often, what is the duration. So very
Dr.
important.
Bender, can I interrupt?
Of course.
Somebody asked, how do we discuss with providers that typing should not be considered a cause?
Providers? No, you're not going to, because again, let me tell you in Illinois, I'm going to give you a little anecdotal study. And this is what the lawyers need to know who are representing you guys. We call it bias. So people in a deposition say, Dr. Vender, you're biased because, the insurance company is hiring you. And of course, they want to hear certain answers. Well, I would like to respond, though I can't, say, well, let's talk about bias. Let's talk about the bias of your treating physician. So you have a 70-year-old person who works in a law office, and they type. Now, of course, nobody types all day. You stop, you do photocopying, you get on the phone, there's no such thing as constant typing. That does not exist in this world, even though everybody says, I constantly type all day. So you have a 70-year-old person who's a secretary, and they come into my office. Their private insurance is Medicare, and then versus work comp. If I do their carpal tunnel release under Medicare, I will probably make $400 and $450. All right. If they're under 65 and not on Medicare, and we go to their Aetna, Blue Cross, whatever insurance they have. It's more than Medicare. It's going to be, say, $600. That's better. Let's go to work comp. In Illinois, I make, I think, $2,300. Now, how are you going to tell a provider to say to this person, it's not work related? First of all, that person's sitting across the table from him. They're going to be upset. All right, face to face. You now have a patient who says, what do you mean it's not work related? Of course it is. You already have an adversarial condition. And the doctor knows, why am I going to fight this patient? If I use their private insurance, they're going to make $500. If I say it's work related, I'm going to make $2,300. So that's my answer as to how you're going to get the providers to change. They're not going to.
Mm-hmm. And then we also have can a shoulder injury cause carpal tunnel?
That's a real good question, because I don't do shoulders, but my partners do, and I still see IMEs that someone had shoulder surgery and now they're claiming carpal tunnel. So they want me to comment on the carpal tunnel. Here's where you can potentially get a positive causal relationship. The shoulder surgery itself is not going to cause carpal tunnel syndrome. However, they're then sitting in a splint, one of those immobilizers, with their arm against their body, their hand against their belly in a dependent position. That can cause swelling in the hand. Swelling in the hand for normal people is no big deal. For swelling in the hand for someone who is predisposed to carpal tunnel syndrome may push them over the edge and cause carpal tunnel syndrome. So in the state of Illinois, any contribution, even if it's small, is considered cause related. If you're looking at it, did it contribute 50%? I don't know how other states work. No, little swelling does not represent 50% causation. But in Illinois, if I say, yeah, could that contribute? Done. It's positive cause related, even if it's a little bit.
Okay. And then we also have, can thumb contusions cause carpal tunnel?
So the answer is simply no. The answer is, I'm going to keep it simple. No. You did, to get traumatic carpal tunnel syndrome, because that's what you're talking about, carpal tunnel syndrome from an accident, a single accident. You want to look for injury to the wrist. That's where the carpal tunnel is located, in the wrist. And when I say injury, I don't want to hear that they opened the door at work and felt pain in their wrist. That's not an injury. Right. I want to hear they fell at work, landed on their hand, they went to the emergency room, there was visible swelling, they had loss of motion. Again, I use the word swelling, right? The swelling can cause carpal tunnel syndrome. So if that contusion to the thumb is truly localized to the thumb, no, I'm not going to say that's a causal relationship.
And blunt force trauma could, I would imagine.
Well, it's a tough one. I mean, we treat wrist fractures every day in this office. That's about as much trauma to the area of the carpal tunnel as you can get. Maybe 1 out of 10 will do a carpal tunnel release at the same time. Prophylactically, if they have some numbness. Maybe 1 out of 10 will end up doing a carpal tunnel release 3 months later, or not even 1 out of 10. So with all this trauma, why aren't more people getting carpal tunnel? But at the end of the day, because again, I can't say nothing is related, otherwise they already think I'm too conservative, but at least if there's evidence of injury to the carpal tunnel, I would say it's related. So again, trauma, but there's got not just blunt trauma. It's like getting kicked in the shin. That's blunt trauma. It hurts.
Right. It goes away.
It goes away. But if you get kicked in the shin and it bleeds and you got swelling and all this, well, that's a little bit more of a trauma. So we have to have signs of, tissue damage.
Okay, great. We'll let you keep moving on.
All righty. I better pick it up here. I want some Q&A at the end. All right. So let's talk about evidence of exposure. This is important. So let's get through this. I'm sorry, my button is a little slow. All right. So this is a concept. Sometimes they say, Dr. Vender, how can you say this secretary didn't get carpal? That person had a lousy workstation. This person said their chair wasn't the right height. and they didn't like their keyboard and they didn't like their mouse. So, let's see if I can get to the next slide. So we're talking ergonomics, ergonomically correct workstation. All right. Bad ergonomics is not going to cause carpal tunnel syndrome. If the person says, my shoulders hurt because I'm all scrunched up at work, that makes sense. But your shoulders hurting isn't a disease. It's a symptom. Okay. So yes, you can, if you have a bad workstation, it can be uncomfortable and fix it, but it's not going to cause carpal tunnel syndrome. Just like sitting on in an airplane for 4 hours going to California, right? Who feels good after that? But it's not going to cause a back condition. You're not all of a sudden going to have a slip disc or sciatica. So yes, we have to pay attention to ergonomics to a degree, but don't let anybody tell you a bad workstation caused so and so. There's always an exception to the rule, but don't, that's the guideline. So again, we're talking about musculoskeletal complaints. At the end of the day, if you really like the work and you believe them, go to the workstation and find it. Back in the old days, we had a person in our office who went on site to assess work conditions. And one day she came back with a film of somebody who had a very unusual shoulder pain, and it didn't make sense. So we look at the video, and what it was, this person sits forward, on their computer, but their document folder, for whatever reason, is behind them, not next to the screen that they're working. So all they're doing all day, and I don't know if you can see me, is looking like this behind them on their screen. So what are they doing? All day long, they're pulling their shoulder backwards and creating a muscle, like muscle cramping. They're doing this all day.
Yep.
We would never figure that out if we didn't do an on-site. That guy would have been written off. It's just crazy, So anyway, sometimes you need to just go out there and look at what's going on. Okay, you're up to bat.
Okay. We're going to let that poll go and you can keep moving.
Okay. All right, let me close that on my screen. Okay. All right, I'm going to start skipping ahead because I want to. The bottom line is, going back to ergonomics, nobody has ever done a study that shows if you give people better work situations, that we're going to get rid of tennis elbow, that we're going to get rid of carpal tunnel syndrome. We're going to get no studies. Yes, they may be more comfortable. Yes, they may work faster and be more productive. But you're not going to get rid of disease. Why? Because disease is part of our lives. We all get carpal tunnel syndrome. And this is going through some of the risk factors of carpal tunnel syndrome. As any condition, whether it's heart disease, cancer, anything, some of us have risks, some of us don't have risks. We just get these conditions. So what kind of things do you look for alternative explanations? First of all, people say, well, why else would I have carpal tunnel syndrome if it wasn't for work? Number one, about half the people we see do not have any risk factors. It's not their age, it's not some of the risk factors we're going to talk about. They just get it. We call that term idiopathic. Maybe half do have risk factors. What are the risk factors? Not crazy about this slide, but just write this down. 4 major risk factors for carpal tunnel syndrome. 1 is on the slide, diabetes. 2 is hypothyroidism. So right now, diabetes, hypothyroidism, very, very common in the population. 3, smoking. No surprise, very common in the population. 4, increased body mass index, being overweight. Again, very prevalent. How many people have all 4 of those conditions? Right? Okay, so those are the 4 major risk factors. Rheumatoid arthritis, pregnancy, all these other things. Well, pregnancy is pretty common, but these are very significant risk factors, but not nearly as common and prevalent as the 4 I just gave you.
Interesting.
And what can we do? There are studies that show aerobic exercise, being healthy. Now it's because you're exercising or because you have less body mass index. Who knows? Sometimes you can't tell why. But these are things. Now I look at getting rid of tobacco, caffeine, and alcohol. I would never say that to my patients because I would never give them up. So I'm not going to tell my patients to give them up. That was supposed to be funny. All right, let's keep going. So again, we're talking about, do you have a disease? Can disease come from exposure? Yes, it can. But has this exposure been demonstrated in this particular patient? So let's go into the other thing for IMEs. They want to know work capability. Now, so you have somebody who does have a problem. They have tennis elbow. There's two ways. Oops, let's go back. They have two ways of giving work restrictions. One is disease specific. When we talk about tennis elbow, there's certain things that will bother you. So I talk about don't do lifting with the palm down and the, reaching away from your body. So that's specific to tennis elbow, or it could be job specific. I look at a video and I see 10 different jobs and I say, 8 or 10 of them should be no problem for someone with tennis elbow. 2 of them, not so good. So then I can give a restriction that says don't do job so-and-so and job so-and-so. I can be specific as it relates to that person's job, but I need information. Okay, poll question 3.
There we go.
Okay, so I'm going to keep going.
Great.
Oh, so work restrictions. It is rare that I would restrict someone with carpal tunnel syndrome. Very unusual. Someone runs a jackhammer, they can't hold it if they have carpal tunnel syndrome. So, right, you restrict them. But a routine laborer, a machine operator, they don't need restrictions. It's a condition of inconvenience. Your hand falls asleep, shake it out, and keep moving. Okay, so you don't need restrictions for carpal tunnel syndrome. All right, keep moving. All right, so this was the disease specific. This is for tennis elbow. Certain types of gripping, that person in the middle, bad position for tennis elbow. The elbow's extended, the palm down, then grab. You are stressing the tendon that's involved in tennis elbow. Again, job specific. All right, you showed me all these different jobs, and they can do this, they can do that. Just avoid that last one. That's looking for trouble. They're going to complain. This is one of my favorite things, especially trying to get somebody to MMI and getting them back to work. They have a little something wrong with them. They're not 100%. Just get them back to work. If you push somebody back to work, all these people who don't want to go, you just say, get your rear end back to work. 80% of them are going to stay there, not complain, and move on with their lives. Then you got the 20% who really don't want to go back. All right, so they're going to be the ones who say, if difficulties are encountered. Then if that happens, they send them back to me and say, okay, what are they complaining about? They didn't like going back to this particular line at work. All right, show me what that line is. I look at it on a video and say, maybe they're reasonable. Don't do that. Okay, so if you just call their bluff, as I say, just get them back to work. Most people are just going to finally go back to work, even though they're still complaining to you in the office that they can't.
Alrighty.
But one thing I'd hear, so I didn't know it wasn't going to be in the slide. Just give me one more minute. Going
Sure.
back to evidence of disease, or no, not evidence. Going back to, are they exposed to a problem at work? Is there something happening? And also, can they go back to work? Job information is crucial. And we get a lot of checklists. We get a lot of written job information. Not only is it insufficient most of the time, it's actually counterproductive. I get checklists that say they're frequently doing this, frequently doing that. They're frequently, because these are artificial definitions. And it sounds like a hard job when you start doing a checklist. Doesn't show me the dynamics. So I would be very careful on written job descriptions. They're either insufficient or counterproductive. So what is the best information? Videos. I could see what they're doing with their arms. You can see whether they're grabbing hard. You can see their forearms. You can see the muscles in their forearm activating. You can see how long they're grabbing for. I can now see that that person is lifting the box not only 50 times a day, but they're carrying it to 2 feet, not to 20 yards. And of course, when you do get a video, it's a little investment in time and money. It does have to come with a good written job description that correlates, that explains what you're seeing on it. So job information is the most important thing for determining causal relationship. All right, questions, please.
What qualifications should we look for those administering an EMG?
Oh, that's a great question. Oh, because I see people who are qualified. They have extra board certification in this field because there is a board certification for it. So number one, make sure it's a real doctor doing it, not a tech, which is basically illegal. I've seen therapists do EMGs. How they're not in jail, I don't know, because it is illegal. You're supposed to be a physician for that. I would look, I like neurologists the most. Physical medicine, rehabilitation, PM&R doctors are fine. But even the guys who are trained well, some of them are very skimpy. They do very limited tests, especially now that they're not getting paid much for it. So I'm not going to give you a good answer on that.
And I would assume what about, have you heard of neurological chiropractors?
Oh, well, don't quote me on it, but I would never trust a chiropractor to do anything like that. They should not be treating, at least they should not be treating hand and upper extremity disorders, period. You
Okay.
know, sore back and a little, they're like, a lot of times the work they do sometimes is like a therapist. Now,
Mhm.
obviously, I believe in therapy, right?
Mhm.
But they shouldn't be doing upper extremity work, period.
And then we have one of our listeners saying, I have a few providers that always want an FCE, a functional capacity exam, with an IME once treatment has concluded, especially on complex carpal tunnel. Do you feel both of those are warranted, or do you think it says, do you feel most carpal tunnel syndromes are rateable?
Okay, well, that's a fairly easy question. When you say both, was the FCE and what else was in there?
An IME.
Oh, an IME. Oh, God, no. Jesus. See, that's just a doctor shirking their responsibility. They don't want to tell the patient to go back to the work. Okay. If you can't get a patient back to work after a carpal tunnel release, you should not be doing carpal tunnel surgery. I mean, that's as basic. Now, to say you never have a problem after carpal tunnel release, I'm not going to be that direct, okay? But if
Hmm.
you can't, I mean, this is good for my business. There is a doctor in Chicago who gives everybody 10-pound restrictions after carpal tunnel release. That doesn't fly. Zero restriction. Zero. Okay, so he's good for my business. I get all these IMEs. So the answer is no. In general, forget about carpal tunnel. Even after more significant things than carpal tunnel, the doctor knows what he did. He doesn't need an IME to verify that he did a good job. If he's not doing a good job, then he's bad. And he certainly doesn't need a functional capacity evaluation. He knows what carpal tunnel release does. It does nothing to the hand. So even in bigger injuries, if I order one FCE a year, whether it's to help me in an IME or in my own patients, that's a lot. That's a lot. Because all
Hmm.
you're going to do is get back bad information. Like the IME, like an IME I did today had an FCE. They need to lift 100 pounds for their job. They were only lifting 90. So that technically eliminates them. Now I'm going to say there's no difference between 90 and 100. How often is he have to lift 100? And was he able to lift 100 even before his injury? You know, how many people are, this is a small guy. How often, where did this number 100 come from? You know, and if he has to lift 100 pounds twice a day, let him go get help. Because if it's 105 pounds, he's going to go get help because that's not required. So let him go if it's 100. So this whole idea of FCEs is bad, bad. You know, the best stance you could ever take is deny. No FCEs. You only get bad results from them.
So if a worker's on-the-job exposure caused carpal tunnel, as their provider says, how soon would you expect symptoms to appear after their last day of work? Is it possible for symptoms to appear 12 to 15 months after they left employment?
Yeah. So there's two parts that there's another half. Another question you could have asked too is time of exposure. First of all, the easy question is, yeah, no, they developed it 15 months later. No, that's not real. Just like if they broke their wrist, which can cause carpal tunnel syndrome, but developed 15 months later, no, there should be some contemporary, something. I would almost say if they had no symptoms while they worked and then they got it, a month later, no. If you're having a problem, you would have known it while you're working. The
Right.
other question is, how long do you have to be doing a bad job before you get carpal tunnel syndrome? So I get the ones where patient's been on the job for a week. Now they're claiming carpal tunnel syndrome. No, not unless there's an acute injury that causes sudden onset of carpal tunnel syndrome. You don't get carpal tunnel syndrome from short-term exposure.
Okay. If a claimant has previously had carpal tunnel release, is it possible for the need for surgical intervention again 10 years later?
Again, good question. I thought it was going to be a little bit different, but good question. The answer is, I used to say you don't get carpal tunnel syndrome again. Well, guess what?
You
I've
can.
seen other doctors and I've redone their carpal tunnel. And a couple times, 10 years later, 15 years later, I've redone a couple of my own. So I
Mhm.
guess the answer is yes, it can happen. It's unusual. And again, it has nothing to do with work necessarily. I mean, some of the people weren't necessarily workers, whether they were my own or somebody else's. So
Okay.
yes, it can reoccur.
And you had mentioned diabetes being an indicator genetically. If it's well controlled within range, does it still contribute?
Great. These are good questions. Let's stay here for another hour. I'm ready. Um, the answer is doesn't make a difference. They have the condition, it affects their body.
Okay.
Probably not as bad as if it wasn't controlled, but just because it's controlled isn't good enough.
Okay. And then in a factory setting where there's hand intensive duties or use of vibrating tools, can that alone cause carpal tunnel?
Again, I want to know the exposure. Vibration by itself, because that was once considered an independent risk factor. Just putting your hand on top of your desk that's vibrating, you're not going to get carpal tunnel syndrome. Vibration is a modification of force. So if you're holding on to a jackhammer, it's not running, all right, but it's heavy. It's heavy. You're holding onto it forceful. Now you add the vibration. Oh, now you're really holding onto it forcefully.
Sure.
So it's that vibration that can modify the force factor. So the answer is, how much are they doing it? Goes back to the evidence of exposure.
Okay, great.
That is a risk factor, yes, but how much of the risk factor how often are they being exposed to it?
Okay, great. How about can you tell us a little about non-surgical strategies to treat carpal tunnel and how effective they are?
Well, the good news is they're not very effective. All right. People who order, I own my own therapy, right? I never send someone for carpal tunnel treatment to therapy unless they insist on it. Doctor, I don't like what you're saying to me. I want to go to therapy. Fine, go to therapy. But it's not going to do anything. Two, you hear wrist splints. Wrist splints don't cure carpal tunnel syndrome, but they can help some of your night symptoms. People wake up in the middle of the night with carpal tunnel for whatever reason. And a
Okay.
lot of times that'll help their night symptoms. You don't wear it during the day because it gets in the way and causes other problems.
Okay.
Three, we do steroid injections. So if you're pregnant and you have carpal tunnel syndrome, I'll do a steroid injection because they'll give you temporary benefit.
Right.
And then hopefully when you deliver, you don't have the same problem and it goes away. So I do steroid injections, but it's not the definitive treatment for carpal tunnel syndrome for someone who has it chronically.
Okay. Can brachial plexus injuries cause carpal tunnel?
God, these are great questions. The answer is people like to talk about a double crush syndrome, where you have an injury up here to the nerve, and then maybe something's going on in the carpal tunnel. That's a whole can of worms. But the
Okay.
answer is it shouldn't. It's different parts of the nerve, different part of the body
Mhm.
by itself. Again, if you have a brachial plexus injury and the arm's dependent because it's somewhat paralyzed, remember the shoulder question, shoulder surgery question, your arm is down. Does that lead to something? The hand is swelling. but a brachial plexus injury by itself, I do not believe should cause carpal tunnel syndrome.
Okay, wonderful. All right, well, we're going to try and wrap things up. I know we did not get to all of the specific questions today, but we do have a time barrier and we want to make sure everyone gets back to their next spot. And we know people are starting to jump off the call. Dr. Vender, this has been fantastic. Hopefully, we can have another session with you down the road on another topic. And for everyone on the call, thank you for participating. Thank you for doing your poll questions. And be sure to answer the survey so we can get some additional topics for you down the road.